Bonsoir. Donc, le débat va bientôt commencer, donc je vous demanderai un peu de silence et si c'est possible de mettre
Chaque année, plus que 17 millions de personnes affectées par cancer. Là-dedans, 4,6% c'est des enfants. Les capables de enfants, de voisins ces enfants. Ces enfants-là, tu peux capable venir infecter docteur pour sauver de la vie. Mais bien souvent, le bas de l'action arrive trop tard. Peu importe qui tu étais, ta contribution comptait. Ensemble, à nous donner un sens, chaque enfant.
Mola et mot capable.
Mola et mot capable.
Mola et mot capable. Mola et mot capable.
Moi, Mola et mot capable.
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 Parce que chaque l'action comptait. Ensemble, à nous contribuer pour sauver la vie de nos enfants.
Good evening, everyone, and welcome to this live debate with Enrave and Sourire. So tonight, to animate this debate, we have a pleasure and honor to welcome Dr. Kevin Teerovengadum. Welcome, Doctor.
Merci de l'accueil.
And we also have the honor of the presence of Dr. Purvi Kutty. Good evening, Doctor.
Good evening. Thank you for having me here.
It's a pleasure for us.
Thank you.
So today, before going on to the topic, which is oncology, I wish to highlight that at Enrave and Sourire, our main aim, before when we started, was to provide equal chances to every child who needed medical assistance and support. And since its creation, we had the opportunity to benefit from the exceptional support from doctors, ambassadors, and members. And tonight, my first question for Dr. Kevin will be, as an expert, I will speak in Creole, maybe.
Ok, c'est mieux.
En tant qu'un expert docteur et avec l'expérience à la fois dans le secteur privé et public, quel œil que vous apportez sur le côté oncologie à Maurice? C'est quoi les avancées? Et qu'est-ce que vous pouvez nous dire? Quelles sont les améliorations à avoir à Maurice?
Merci de la question, Delphine. Donc, moi, le docteur Kevin Teerovengadum, un chirurgien pour enfants, je suis cancérologue pour enfants, mais on traite beaucoup d'enfants avec cancer. Donc, moi, Maurice, depuis 2009, quand dire depuis 2009, il nous fait beaucoup de progrès. Et le progrès, peut-être le plus important, c'est qu'en 2009, les enfants, tu peux gagner chimiothérapie dans la salle adulte. On vous rappelle quand on retourne Candos, pas dans la salle dédiée à les enfants. Et c'était vraiment choquant. Quand moi, je me suis fait une quinzaine d'années en France, je me retournais, je trouve les enfants dans la salle adulte, puis un chimio au milieu d'un adulte qui a un cancer, et des fois assez choquant pour les enfants, puis les adultes souffrir, etc. Donc, la plus grande avancée, je pense, aux 10 dernières années, c'est la salle à l'hôpital Candos, la salle 14, qui regroupe tous les enfants et les adolescents qui ont un cancer. Et donc, mes parents, quand même, se retrouvent ensemble et un esprit quand même d'entraide dans cette salle. Et si nous avons continué, les problèmes, par contre, qui nous énormes, le problème numéro 1, c'est qu'il nous paye un cancérologue pédiatre dans Maurice jusqu'à aujourd'hui. Et, par exemple, là, nous avons la chance d'avoir... I'm sorry to speak in Creole, but I'm saying that the main problem that we have here, that is we don't have a cancer specialist dedicated for children. So, of course, the adult specialists in cancer care have to cater for the children. They don't have the choice, they have to. But the thing is, we have only approximately 50 children per year suffering from cancer. If we count also the adolescents with leukemias and lymphomas and bone tumors. And so 50 cases per year, it's rare, it's a rare cancer, compared to we have approximately, I think, 1,500 cases of adult cancer per year in Mauritius, so 50 is a little, but these 50 children need care, and they need the best possible care, and that's where événement comes in action, because I think they've changed the lives of many children for them to have affordable care and the best possible care. So we have, I say, three stakeholders. We have the public sector with the child cancer ward, which is Ward 14, which you have the chance to visit in the hospital. Then we have the private sector in Mauritius. I work at Welkin, maybe it can be other clinics also, but we have the management there has invested a bit in the equipment and trying to get the best possible care for children. And then we have, of course, all your expertise in abroad, particularly in India, where, of course, you have big tertiary centers that cater for lots and lots of children with cancer, and you have the expertise that we cannot have because we are a small island and we don't have so many children to treat each year. So we have to be able to work together, the public sector in Mauritius, the private sector in Mauritius, and all the NGOs and abroad. Yeah.
If I can say something, Doctor, you mentioned something really important. Aujourd'hui, est-ce qu'il est possible de nous donner des soins aux enfants avec un équipement dédié aux adultes? Est-ce que c'est une affaire qui est faisable? Est-ce qu'il est acceptable? Prenons conscience oui. Que c'est quelque chose qui se fait ici oui. À Maurice. Hein?
Alors moi, c'est depuis mon retour à Maurice en 2009, c'est un petit peu mon combat, hein, pas juste en cancérologie pédiatrique, mais aussi dans chirurgie pédiatrique en général. Moi, je pensais à des enfants, bien qu'il y ait un soin par l'équipe qui habite très de des enfants, que ce soit anesthésiste, infirmière, toute l'équipe, est différent complètement parce qu'il y a une maladie là différente et façon de traiter différent. C'est sûr que nous résultats pour meilleur si nous gagnons l'équipe qui habitue à traiter des enfants. Mais parfois quand on paye un choix, si vous payez un chirurgien pour les enfants, pour payer des enfants, même un chirurgien pour adultes, puis ça opère les enfants là. Hein? Mais si nous avons un choix, et moi pensez à Maurice en 2022, quand même, nous venons d'un pays relativement développé et nous avons besoin pousser pour que les enfants gagnent les meilleurs soins possibles. Oui.
Merci, docteur. Merci. Donc aujourd'hui, notre focus, c'est sur l'oncologie. Pourquoi? Pour ceux qui ne savent pas, dans les pays qui sont surdéveloppés, 80% des enfants qui ont besoin de ces soins ont la chance de survivre, à comparer à des pays qui sont sous-développés, où sur 2 enfants, un seul, il survit. Donc aujourd'hui, Doc, étant donné que nous pécons un sujet oncologie, vous, aujourd'hui, vous recommandez peut-être d'avoir un médecin qui est spécialisé, un oncologue pédiatrique oui. À Maurice?
Oui, c'est pour idéal. Si nous avons un cancérologue pour les enfants, en fait, c'est qu'il nous besoin comprendre quand nous avons un spécialiste dans un domaine, ce n'est pas juste la personne. Il pousse toute l'équipe vers le haut, que ce soit dans le diagnostic, parce qu'un des problèmes qui nous gagnons quand nous avons un cancer que des enfants, c'est le délai de diagnostic. C'est-à-dire, entre les enfants, I'll speak in English because I think it will interest you. So, one of the main problems we have is the diagnosis is sometimes not very timely, and because we don't have this specialist in cancer care, there is often a very long delay, and then to begin the treatment, they try to try everything else, send the child abroad, and do lots of other things instead of starting the treatment, because an adult oncology specialist will always be a little bit more afraid of complications related to chemotherapy or any other treatment given to children. So very often when these children reach you in India, you'll confirm, but I'm sure you'll say, why didn't they give something before. Yeah? This is a main problem. And then another problem we have is in the maybe in the lab, because now a lot of these diagnoses needs complex things like something called cytoflowmetry, which we don't have.
PET scan, these basic facilities to timely diagnose the cancer is not available here, unfortunately.
Yeah.
But I think this is a great platform where we are raising the question. So we will kind of make it available when I come next time. Everything will be there. I'll just come to, set it up. I feel happy that at least we are raising the concern that these children are not getting timely access to the treatment, timely access to the doctors, timely access to anybody picking up a small diagnosis of a cancer. So there may be, it's very rare. That's why pediatricians or any primary healthcare provider may not pick up the signs of childhood cancer. But I think it is the right time that we are addressing this issue so that these children get access. No child should be denied the chance to reach at least where the treatment is happening. But I guess they are doing so well here. Now he's just discussed some of the complex cases, and we can see such happy faces in the audience that just says it all, that they have got the access and they were the lucky few who could make it out of the treatment and they are doing fine.
Thank you, doctor. Donc avant qu'il nous continue avec docteur, nous pouvons visionner une petite vidéo. Mais avant cette vidéo-là, est-ce que vous avez un petit mot pour partager, docteur, par rapport à Luna qui ont traité?
Oui, Luna pas du tout dans la salle 14, il est une directe dans privé, il une jeune Madame Odile qui est là. Donc, c'était un cas d'un cancer du rein, puis mon cas dire, et puis il gagne le traitement selon les guidelines avec ce chimiothérapie avant. 4 semaines de chimiothérapie, ensuite une fait seule opération. Et là, nous avons plusieurs années après la chirurgie, 3 ans, comme le temps de finir plus 4 ans. Et il peut faire très bien. Donc,
c'est une success story for us.
Oui, comment tu peux dire, dans un pays développé, jusqu'à 80-90% de mes enfants qui survivent. Hein, c'est surtout pour une tumeur comme ça, qui appelle un néphroblastome, c'est une tumeur des reins. Normalement, le taux de survie de ces enfants-là, si je gagne le traitement approprié, il est très élevé. Et nous sommes bien capables, à Maurice, sauver ces enfants-là avec un protocole qui peut servir dans tout un pays développé. Donc, oui.
Merci beaucoup, docteur. Donc maintenant, nous allons visionner la vidéo de Luna.
Bonjour, je m'appelle Luna. J'ai 4 ans. Mais tu es malade. Mon bien sorti. Je me remercie maintenant et moi. Mon bien. Je suis content sorti. Mon père est à l'école. J'ai mon grand frère. Je suis avec ma cousine. Je suis dans la piscine. Mais c'est 20%. Je fais jolie fille et alliée.
Thank you very much. So, Dr. Purvi, as a bone marrow transplant specialist and a pediatric oncologist, I would like you to discuss about what are the techniques that are used to diagnose early the signs of cancer in children, and what are the techniques that you use and you have used that works and that you can bring as a support to Mauritius.
Yes, thank you for the question. I think one of the biggest lack is awareness of the signs and symptoms of cancer. So first prong in bringing down or closing the gap to care would be educating pediatricians, educating primary healthcare providers, educating the government who are handling the children at the first point of contact to pick up these subtle signs and symptoms of cancer. So anything which is prolonged or persistent in a child who's losing weight, who's not happy, who's not playing, he's having prolonged fever for more than 2 weeks, prolonged swellings anywhere in the body for more than 2 weeks, not settling with antibiotics, don't ignore it. As a parent, don't change your doctor, change hospital. As a pediatrician, make a note, yes, this fever is lingering on for 2 weeks. Maybe I need to do a simple blood test. This is available everywhere at the bedside. A CBC. Is it showing anemia? Is it showing abnormal white blood cell counts? Are my platelets okay? Is it lingering on? Is this something affecting the bone marrow? Because the commonest cancers we see in children are blood cancers. So these don't require to pick up that this child may have a blood cancer or a lymphoma, which is arising from the blood system. It's not rocket science. It's very easy to pick up on a bedside CBC. So you need to be aware what the symptoms are. The child will lose weight, he'll have failure to thrive, he'll have persistent fever, persistent swelling. So anything going longer than usual. In a child, of course, so many children have fever and have swellings in the neck, which is very common. It's seen almost universally in all the children. But when it is persisting beyond the period, more than 14 days, child is having weight loss, he's looking pale, he's looking sick, he's stopped to play. Yes, do I need to order a CBC? It's very easy bedside test available, and we can pick up when the counts are too high or too low, when the platelets are low, when the hemoglobin is off what has to be the routine. Yes, then there should be a flag. This is a red flag that I must think of cancer in this child. Some of the solid tumors also are in fact picked up by the parents when they feel a lump which is not settling or not going down while bathing the child in case of a kidney tumor or an abdominal mass. So they just are bathing the child or something unusual. So it's very important to have a bedside examination even for the doctors and for the parents not to ignore these swellings which are persisting. When the child is having a headache which is lasting more than 2 weeks, he's walking all the while and now he's lost his milestone. So he stopped walking, he's swaying, he's having unusual headaches which are lasting. So these are all subtle signs of brain tumors, which are the second common cancer we see in children. So it is not too difficult that to pick up pick up any sign of cancer in a child. We don't need a sophisticated test like a flow cytometry or a cytogenetics or a PET scan at the first bedside. So we should close the gap to pick up these subtle signs which will red flag, yes, this child needs to be worked up for a cancer. Then comes in the order of the high-end or the sophisticated test, which can be ordered at a tertiary care cancer center you all are having. So we can do a bone marrow there. Maybe flow cytometry is not available, but we can start pre-phase steroids so that we cut down the delay to initiate treatment. Because the longer the child makes a later diagnosis or the longer we initiate the treatment, the outcome is going to fall. So at the right time, by the right team, when we make a diagnosis, it's essential that it should be done so that the child has the best overall outcome. And childhood cancer is treatable if it is picked up at the right time. So that is what I'm emphasizing here. It's not rocket science. You don't need high-end machines or high-end tests. It's just the awareness. We need to close the gap by educating what are the red flag signs. So as your NGO, I guess you should put up the red flag signs at all the public health hospitals or all the cancer wards so that people are aware. The tip of the iceberg, maybe 50 cases you all are seeing, but another 50 are not reaching the hospitals because they are not picked up early.
Thank you very much, Doctor. Do you wish to add anything, Dr. Kevin, to what Dr. Purvi just said?
No, it's quite complete that she said.
It's fine.
Yeah. So a lot has to be on education.
Yeah.
Education of doctors, of primary care.
I do totally agree that awareness is primary.
Yes, that is the primary.
Yeah.
And then when we get the child See, when I get a child, mine is a tertiary care center at Apollo Hospitals, Navi Mumbai. We have everything in-house. So we have the PET scan, nuclear medicine, the radiation planning can be done. We have a blood bank which can do the stem cell collection for us when we have to take up a child for a bone marrow transplant. So we have each department in-house. Maybe most of the hospitals, even in India, don't have that facility. We are lucky that we are a tertiary care city with everything in-house. But as we see the child, maybe we already have a suspicion that this child has come to me for a blood cancer. Then I will raise the labs for the bone marrow test. So I don't need to do the bone marrow again. We send the flow cytometry, we send the karyotyping, the cytogenetics. Everything is available in-house. But even if it's not available at your center, so that doesn't mean that there should be a setback or there should be a worry that I should not treat this. You can take the bone marrow sample, we can collect it in tubes. You know, the cells live on for 2 to 3 days. So it's easy to transport with the patient. So the patient doesn't have to go for the procedure again. And every child, we usually start with a pre-phase steroid, if it's a leukemia, or COP or CHOP just for a lymphoma, so that they don't get more sicker. And if there is any delay in the diagnosis, we always like to communicate. So we know, we see the face of the doctor, we know that we are on the same page. Because when I came here and met all the doctors, I know they are thriving, they are worried about their patients. But there is a delay in the system till the patient reaches us. So we can always communicate that some antibiotics can be given as a prophylaxis. And the best supportive care is started here till the higher end tests are required. Of course, these children in today's era, if they should have the availability of all the high end tests like MRD, flow cytometry, cytogenetics, PET scan. These are mandatory for treating childhood cancers because they will optimize and they will guide you how the therapy should go. Most of the therapy in blood cancers goes on for 2 years. So with having this information early on, we know which child will require a more higher treatment, may require a bone marrow transplant, and this child is going to be standard risk. He's not going to require a bone marrow transplant. My high-end tests will just tell me how to tailor my treatment. It's not going to change my diagnosis. So even as a patient, I tell them, don't get too worried that you need to come here and do the scans again, or you need to get the bone marrow done at a higher center. First, make the diagnosis. Start the basic treatment. We can have an open communication, a channel where the first phase of treatment is started so there is no delay. And then, of course, we can go in for the high-end tests so that we know how to tailor the treatment so that if it's a low-risk cancer, they are not given too much chemo. If it's a high-risk cancer, we tailor it. We know it's going to be a bad prognosis. We need a bone marrow transplant. So then we go for help to your NGO. So these children are going to require longer care. So this is the higher-end tests usually are just sophisticated and they give us more information on how we tailor treatment. As far as the treatment goes, it is about 4 or 5 modalities. Mainly childhood cancer is treated with chemotherapy. Of course, the solid tumors also require surgery and they may or may not require radiation therapy. Then we need the help of our expert surgeons and the radiation oncologists because for a child we do not over radiate, we need to save the surrounding tissue as they are going to grow up. As childhood cancer is curable, we are not looking at giving them 5 more years of their life. We are looking at them growing to young adults, going to college, going to university. So we try to minimize the side effects also with the therapy. And unlike adults, in fact, it's a myth. Children tolerate chemotherapy very well. So there is nothing to be worried that, oh, they are not going to take the side effects, he's going to get sick. In fact, they tolerate heavy, high-dose chemotherapy beautifully. So it's just being aware of what you're giving, the doses you give, and the planning. That is most important.
Thank you very much, Doctor. So, as you're all aware, oncology is one of our main topics. Why? Like Dr. Kevin just said, 50 children are affected by cancer per year in Mauritius. And our aim today is to develop appropriate strategies to address these children and to join our objective, which is to give equal chances to everyone. And to take from you what you just said, Doctor, is that children, we are not going to save them like 5 or 10 years more.
Absolutely.
It's for a lifetime. Yes. So we want them to grow, to go to school, just like Luna, to be able to play again, to get married, to have children, and to live her life. So to finish, I wish to thank both of you, Dr. Kevin Teerovengadum, Dr. Purvi Kutty, for your time, for your explanations, and for your speech, because I think everyone here in the audience, whether it's patients or ambassadors or people who are here to support us, we have learned so much things.
Thank you.
To finish, I wish to say that for the 5th year of Enrêve un sourire, we have proudly sponsored the video clip of Mr. Love, and I invite you to discover it in exclusivity with us tonight. Thank you.
Salut à tous, alors moi c'est Mr. Love, ambassadeur de l'association Enrêve un sourire. Aujourd'hui, on a l'immense plaisir pour présenter un nouveau clip collé serré qui est sponsorisé par l'association. Mais avant qu'il nous diffuse le clip, c'est quoi Enrêve un sourire? C'est une association bien sûr qui est là comme mission pour aider les enfants qui ont le besoin, qui ont une maladie bien grave. Mais sans autre support, nous ne sommes pas capables de faire rien. Grâce à ce don, généreusement, qu'ils sont capables d'avoir le numéro compte qui est affiché, nous sommes capables de faire des enfants dans cette guérison. Moi, je vous souhaite un grand merci en avance et moi, je vous souhaite un bon visionnage. Merci beaucoup.
Bonjour et bienvenue dans ce JT un peu spécial de Enrêve un sourire. Dans l'actualité d'aujourd'hui, nous allons découvrir comment la pandémie de la Covid-19 a chamboulé le quotidien des Mauriciens. Nous retrouvons tout de suite notre envoyé spécial pour plus de détails. Bonjour Roxane.
Mr. Love, come again. Yes, beautifully, beautifully, beautifully pretty girl. Son Dieu m'en finit par pour nous passer une petite soirée. Yeah. Beautifully, beautifully, beautifully pretty girl. La musique finie ready. Nous pour bouger toute la nuit. Vibration là, les t'entends. Liste l'écho, aller en mouvement. Oui, nous pour faire ça doucement, 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 doucement. Oh, vibration là, les t'entends. Liste l'écho, aller en mouvement. Oui, nous pour faire ça doucement, doucement. Nous prend tous nous les temps. Ouais yo, pour petit manque mon cerveau. Ça fait la oui Mariso. Ouais yo, peine à s'écrire le tableau. Ça fait la maritoto. N'a pas besoin, n'a pas besoin, n'a pas besoin qui hésiter. Fais-moi plaisir, venez nous coller serré. N'a pas besoin, n'a pas besoin, n'a pas besoin ou refuser. Maman happy quand nous danse coller serré. When I'm murder on the dance floor. Quand nous tous les deux nous danse corps à corps. N'a pas besoin de toper à mon coup, certains faux nous dit en accord. La buena murder on the dance floor. Quand nous tous les deux nous danse corps à corps. N'a pas besoin de toper à mon coup, certains faux nous dit en accord. Bouségal, Bouségal, haha, Bouségal. Hey, joli gars, maman Marie a prêché. Façon qui ou déhancer, ou préfère moi inspirer. Oh, sexy gars, pas plus capable de résister. Ou fait ça Marie sérieux, si ce qu'a fait mon ligo frissonner. Oh, vibration là, les t'entends. Liste l'écho, aller en mouvement. Oui, nous pour faire ça doucement, 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 doucement. Oh, vibration là, les t'entends. Liste l'écho, aller en mouvement. Oui, nous pour faire ça doucement, doucement. Nous prend tous nous les temps. Ouais yo, ou petit manque mon cerveau. Ça fait la oui Mariso. Ouais yo, peine à s'écrire le tableau. Ça fait la oui Litopo. plaisir, vini nous coller serré. N'a pas besoin ou refuser. Maman happy quand nous danse coller serré. When I murder on the dance floor, comme nous tous les deux nous danse court à court. N'a pas besoin de toper à nous pousser à ta faute, nous dit en accord. La buena murder on the dance floor, comme nous tous les deux nous danse court à court. N'a pas besoin de toper à nous pousser à ta faute, nous dit en accord. Bouségal, Bouségal, haha, Bouségal. N'a pas besoin qui hésiter. Fais-moi plaisir, vini nous coller serré. N'a pas besoin ou refuser. Maman happy quand nous danse coller serré. N'a pas besoin qui hésiter. Fais-moi plaisir, vini nous coller serré. N'a pas besoin ou refuser. Maman happy quand nous danse collé serré. Skidi bam bam bam.